Bismillah. Thank you very much, Dr. Leslie. Good morning and assalamu alaikum. Before I start my presentation, I would ask to have a honor to congratulate all midwives on the International Day of Midwifery. And speaking of the preeclampsia and eclampsia, we heard from all the speakers, previous speakers along this morning. We found that actually preeclampsia and eclampsia is still a mystery for us. All the effort to find out what is the cause, what is a thing that we can do to prevent, still evolving, as we know. So I would like to just have our focus in the principle of management of preeclampsia and eclampsia on two things that we can see here. That is the early identification and diagnosis of preeclampsia and eclampsia. The second is the prompt and timely management of preeclampsia and eclampsia. As we know, it consists of several things, including prevention of seizures, control of blood pressure, evaluation of mothers and babies, and timely management and delivery. In Indonesia, there is we can start all the two things as early as at the community level. So if we saw, this is the diagram for Indonesia health referral system. Below we see that the community is actually already empowered by the village midwife, the cadre, who are voluntary health workers, and then up to the village health post, which is actually satellite for the primary health care, goes to the private practice of general practitioners and obgyn specialists, and then to public health or primary public health centers, and up to the district general hospital, and then other type or higher type of hospital until the province level of hospital. This actually gives Indonesia an opportunity to actually have everyone in their position of managing preeclampsia and eclampsia. And the other thing, the opportunity that Indonesia already have is actually the training system. We have a national training network for training in reproductive health, and it is actually reached and massively go throughout Indonesia, and it starts from the community, from the village midwife. And also we have a basic emergency obstetric and neonatal training up to the comprehensive in the level of hospital. So speaking of the weapon that we have, actually we have enough weapon. So if we go through the first step of managing preeclampsia, eclampsia, for early identification, stabilization, and referral, the community level actually have, as I said before, a trained volunteer community health workers, and they do identification by knows the danger signs in pregnancy. And also, maybe I should add here that they also are familiar with taking blood pressure. But taking urine protein, as Harshad already mentioned previously, is actually one thing that maybe we can pursue in the coming years. Village midwives or GP in a private practice also have a role. They are doing identification by routine check of blood pressure, but as for the urine protein, it still have some problem that we don't regularly check. So we only check it if the blood pressure is high. So this is also something that we could improve. And stabilization also done by the village midwife. They are allowed to give nifedipine and methyl-dopa, which is I don't find in the previous presentation, for antihypertensive drug. And then also administration of methylsulfate. And then they do referral. And for prompt and timely management, Well, at the community level, we are asked for prompt and adequate proper referral. That is the most important thing, I think. And for the Bimong and Simong facility, they actually, we expect, or they are doing the early continuing management. So if, like previously say that the loading dose is not enough, so loading dose should be together with the referral. And after the referral, the Bimong facility will then continue the management. And then timely and proper delivery also can be done in both facilities. Appropriate monitoring and appropriate referral if needed from the Bimong to the Simong facility, or Simong facility to the higher sophisticated hospital. Although the weapons are there, but still there is challenge that we face. The first is on the community level, that if I compare like 10 years ago with today, the trained volunteer community health workers is actually, well, they are now in limited of numbers. The situation, the social economic progress that happens also restrain the people in the community to join the volunteer community health workers. Knowledge, skill, and attitude as cadre also need to be improved. And evolving policies regarding the village health post management also something that considered to be the challenge of empower these health workers. Despite that, actually the training package are perfect and the funding also available. The other challenge is the midwife scope of practice and also the general practitioners, that we found that they have a limited authorization in emergency condition, such as giving medication, administering IV drugs. Let me tell you a story about a young midwife, which is only 23 years old in a rural area. She just placed in the primary health care for 1 year. And then the primary healthcare got the opportunity to join the Bimong training. And then after finish the training, she come back to the village and she get the patient with preeclampsia, with high blood pressure over 200 over 110. And at that time, even though she's been already training to give magnesium sulfate, she is not confident to give it. And there are so many things that cause that, actually. So we need to have a competent, proficient, mastered, and confident front line in the field. We don't want them to fall like this young boy without someone having hand to be there and help her. So this is what we think of a way to maybe answer the challenge, is to have a continuing education for health provider. We know that in the initial training they have case-based classroom, they have training, they have clerkship, clinical rotation and everything, but when they come to reality, it is something completely different. So they need in-service or on-the-job training and even clinical mentoring so the chain won't break. And mentoring also can be quite complicated if we think of the old-fashioned way of communication, that we can only speak through a tube with a thread on it. But now we are in the era of having such tremendous information and communication technology in progress. So this is the way of mentoring that we can think of, and actually this is something that we developed in one of a recent USAID funded program in Indonesia, that is the MAS program. The other challenge that we shall not forget, similar with any other country here in Asia, that we are having the problem in infrastructure and transportation, socio-economic and culture. As you see that we are in the probably similar condition. The other challenge also for the prompt and timely management and delivery in the CMONG and BMONG facilities, that we all want them to be there 24/7 like Starbucks coffee, but it's not as easy as it is. We have national standards on management of preeclampsia, eclampsia, but the problem in the field that actually they don't agree on that. Even though WHO have a recommendation, probably they're still arguing on things, but we should change the paradigm on that, I think. The policy of decentralization of health system, which is recently being done in Indonesia, it's also something that it should be improving the health system, but the fact is sometimes it's obstructed what is policy from the ministry to the district level. The other challenge is the high turnover of health providers, which is also something that become our concern. And then limited human resources with urban bias. As we know that a big city always invites everybody. The last thing is the non-functioning. I'm sorry, this should be interpreted as BMONG certified health facilities. So they are already trained, but they are not functioning because all the things that I've said, that the doctors are away, the midwives are having other training, so they're not functioning as it is. So this is my last slide, that the strategy should be including all stakeholders in the country, I think. Strengthening the community engagement, including public engagement in the maternal and neonatal health field, and then develop and operationalize standard clinical guidelines on preeclampsia, eclampsia. We really should have to sit together and decide. And then update health providers' knowledge and skills on preeclampsia and eclampsia, strengthening the role of midwives and general practitioners. As you know, general practitioners should have more role in stopping the mother's death. Strengthening healthcare system, which I think need a commitment and a clear strategy and action plan. Thank you very much.